very happy to see so many faces here, and also very happy to have got such a setting and such an introduction to the next theme that we're going to be discussing with this esteemed panel. So we are basically going to be talking about nutrition in India. And in particular, we're going to dive into the issues of implementation challenges. But of course, we wouldn't be 3IE if we also wouldn't talk about evidence and what evidence we do have in relation to implementation challenges. And as well as in our panel, we hope to also draw the larger lines, because implementation challenges is something I think we are well known in just about any sector that we work. So I think there are some lessons that can be drawn across sectors. Now, let me just take a couple of minutes to put the stage here. Dr. Agarwal in the previous panel mentioned that India is number 102, ranked as number 102 on the hunger index. So that sort of sets the stage for some of what we're going to be discussing. One of the major global health challenges of the 21st century is reducing various forms of malnutrition. And then we're talking about not only underweight, but also micronutrient deficiencies and overweight and obesity. So notably, 2 billion people suffer from some form of malnutrition in the world. Moreover, approximately 160 million children under the age of 5 are stunted, and about a third of them, 50 million, are in India, with girls being particularly at risk. In 2012, the World Health Assembly recognized that child stunting was one of the most significant impediments to human development. And they resolved to decrease the number of children under 5 who are stunted by 40% by 2025. Now, we are basically already, knowledgeable about the fact that this will not be achieved. Or it's at least highly unlikely to be met. And this represents, more than numbers, it's a tragedy. It's a tragedy for the children we're talking about, it's a tragedy for their families, for the communities, and for the nations. So, in a sense, how it has been put by many people is that stunting remains maybe one of the most stubborn global health challenges, and it's particularly stubborn in India. So, without further going into the details, I'll now present my panelists, and I'll do it in the order in which they will talk. So first of all, Stuti Tripathi is an evaluation system specialist in 3IE. She manages a portfolio of studies that evaluate livelihood-based interventions. And prior to that, she anchored 3IE's work on evidence uptake and use. Stuti has worked in a number of other development organizations, including the IFC, or the International Finance Corporation, as well as the Center for Microfinance, IFMR, research. And she holds a Master's of Sociology from the Delhi School of Economics. So welcome, Stuti. Now, after Stuti, I have the pleasure to present Purnima Menon, who is a Senior Research Fellow and Theme Leader for South Asia Nutrition Programs in IFPRI's Poverty, Health and Nutrition Division. Purnima directs POSHAN, or I'm sure many of you know, it's the Partnership and Opportunities to Strengthen and Harmonize Actions for Nutrition in India. It's quite a handful. POSHAN, I like that. It's an initiative to support more use of evidence for nutrition in India. She serves on several global and national technical advisory groups and has published extensively on nutrition, both in India and globally. And she has a PhD from Cornell University. Then I'm joined to my direct left by Mr. Dr. Alok Kumar, who is a UP, or Uttar Pradesh, for those of you who are not very familiar with the abbreviations of the Indian states. The UP Indian Administrative Services Officer of the 1993 batch. He has a master's degree in public policy from the Woodrow Wilson School, Princeton University. And he's currently working as an advisor for the Health and Nutrition, Financial Resources and Administration at the Niti Aayog. And for those of you not familiar with Niti Aayog, it's a very important policy think tank of the government of India, which was established with the aim to achieve sustainable development goals by fostering the involvement of state governments of India in the economic policy-making process. And last, but certainly not least, Carola Alvarez, who is the chief of the Development Effectiveness Division of the Inter-American Development Bank. She is also a board member of 3IE. Carola has 25 years of experience in international development. She's an expert in evaluation methods, poverty alleviation interventions, and human resources development. And she has also worked extensively on the design and evaluation of large conditional cash transfer programs in Latin America, and particularly on the quite well-known Progresa Oportunidades program in Mexico. She's also been leading institutional-wide reforms in IDB to increase the level of empirical evidence used to demonstrate results from the bank's work. So welcome to the panel, and I'll start with inviting Stuti to present some work that basically Purnima commissioned of us, and then we'll get to Purnima to talk briefly about why you did that, and we'll go on from there.
Good morning, everyone. Thank you, Marie. So I'll get straight into the presentation. And as Marie said, I'll be talking about some work that IFPRI and 3IE are actually doing together. So what we are basically working on is to create a map of implementation research on nutrition-specific interventions in India. And this is the work that we are going to be presenting today. Thank you. I'd just like to introduce you the team that is going to be working, because I'm just presenting on behalf of the teams, and pretty much all the team members are actually in this room. So if you ever want to sort of go and speak to anybody, you're welcome to do so. So Urmi Bhattacharya, Abhirupa Das, Marie Gaarder, Pooja Sengupta, and myself, we constitute the team for this project. So before I sort of deep dive into the specifics of this project, I think it would be sort of important to give you a flavor of what an evidence gap map is, mostly because it is the framework of 3IE's evidence gap map that we are using to sort of build this implementation research map. So what the evidence gap map really does is that it very simply systematically searches and consolidates all the evidence that's available out there for a particular sector and visually displays that stock of evidence onto a matrix. And what does that matrix look like? This is what a prototype of an EGM 3IE matrix looks like. On the y-axis, we have the interventions, and on the x-axis, we have the outcomes. And if you look at these bubbles, what they basically tell us is that, say for interventions on health messaging, how much evidence do we have of interventions that are on health messaging and are having an impact on, say, incidence of diarrheal disease. Similarly, these empty boxes will tell us that there is actually no evidence that we have of health messaging interventions either having or not having an impact on willingness to pay. So this is what an evidence gap map basically tells us. What then is really innovative about the work that we are doing with IFPRI? A prototype of a 3IE EGM is mostly looking at effectiveness outcomes. So let's say, what is the impact of health interventions on health outcomes? So for example, in a nutrition context, it would be, what is the impact of nutrition on health outcomes and some intermediate outcomes that are leading to it? So we have the intervention, and then we have the outcomes. What we don't have, or what we are missing in the middle, is, what are some of the mechanisms that lead to those impacts, or does not lead to an impact? And this is the sort of, as I may say, is a black box that many studies actually don't unpack. I have just listed some three mechanisms just by way of an example, but there can be a whole lot of mechanisms that actually impact delivery of a program. And the implementation map that we are going to be working on is actually going to shine a light on this aspect of interventions. The nutrition-specific interventions that we are going to be looking at, this is an entire list, but I'll just quickly go through the main heads. So we are going to be focusing on supplementary feeding, food fortification, micronutrient supplementation, severe acute malnutrition, behavior change communication interventions, and a couple of additional interventions like delayed cord clamping and if women are actually weighed during pregnancy. So these are the list of interventions that we are focusing on. And in terms of the outcomes that we've identified, which are important for us to sort of map onto that matrix that I just shared with you, we've bucketed those outcomes into 3 broad categories. And this was actually informed by a preliminary review of the literature that we did. And so it's sort of been iterative and has evolved as we got to know the literature better. So we have implementation outcomes at the program level, at the participant level, which is the beneficiary level, and at the frontline worker level. I'll deep dive into some of these in the subsequent slides, so I'm not spending time here. In terms of building this implementation map, as you would agree, an evidence map is only as useful and comprehensive as it is exhaustive in the searches that have been carried out. So in terms of where we looked for literature to populate this map, we drew up a list of some 12 repositories. And here on your right, you can see what was the kind of search results that we got from across these 12 repositories that we'd identified. And we tried to focus on repositories which focus on health. Then we also hand-searched some 44 websites for gray literature, and we also did some bit of snowballing by talking to sector experts and seeing if talking to them could lead us to some other gray literature which we were missing from the first 2 steps. This just gives the quantum of the literature that we have screened. So the systematic search actually threw up over 32,000 records. We screened in excess of 20,000 records for title and abstract. Just a caveat, we didn't do this all manually. We use something called EPI, which also uses machine learning, because otherwise it would have just been impossible to go through all the 20,000. So I think manually we went through something between 5,000 to 6,000 title and abstracts. 1624 records were actually came down for full text screening. However, we could not retrieve some 342 papers. And the full coding is happening for 324 papers. We might add maybe another 20, 30 to this count, but it would be in the range of about 350 records for full paper coding. So what are we actually seeing from the full text coding that we've done? I think this is a very telling slide and something that we would probably like to spend time on. If you look at the kind of studies that have showed up in our searches, only about 38 studies in a pool of 324 are impact evaluations. And maybe if you add to that 7 studies that are both impact evaluations and process evaluations, we are looking at max 45 studies which are impact evaluations. Now this is even less than 15% of the total pool of studies. A bulk of the literature actually is lying in what we are calling the other evaluations, which in a typical evidence gap map of 3i would actually not make it to the gap map. But in this case, because it's an implementation research map, we have about 266 such evaluations which are either pre-post or just one cross-sectional survey study. In terms of evidence distribution, we see that states like Uttar Pradesh, Bihar, Orissa are among the well-studied states, which actually is encouraging because we know that Bihar and Uttar Pradesh probably have the highest burden of malnutrition in India. You will see India there, but that's because some of the studies were not really focusing at a particular state, but India as a whole. In terms of the rural-urban divide, for once, the divide is in favor of rural areas. So 44% of the studies, and add to that maybe 18%, actually looked at rural areas. And here again, this again is very telling because it tells us that there were about 20% of the studies which didn't even make it apparent whether they were studying rural areas or urban areas. So this again speaks to the quality of the literature that we are dealing with. In terms of target population, pregnant women are the most studied population. We had around 130 studies that looked at pregnant women. And we also found that there are actually significant number of studies that look at frontline workers and health workers. In terms of delivery platform, ICDS, for those of you who are familiar with the Indian context, ICDS is a key platform through which many interventions, especially those targeted at pregnant and lactating women and children below 2, or rather children below 5, are delivered. So there is a big quantum of studies that are looking at ICDS. In terms of implementation outcomes, this first slide is talking about implementation outcomes at the program level. And as you would see, among the various implementation outcomes under program level, it's the adequacy and sufficiency of resources which is most studied. So we found 130 instances of where this has been studied. And mostly, if we were to unbundle this number of 130, a lot of these studies are actually looking at either micronutrient supplementation intervention or what we have put here as a bundled intervention. So what we really mean by bundled intervention is that these could be studies which are looking at ICDS system as a whole, or Anganwadi, just looking at infrastructure available at Anganwadi centers. One of the challenges that we are finding as we are going through literature is that even though less than 10% of the studies, even for studies that are looking at implementation outcomes, on average, less than 10% studies are actually taking the next step to explain why they are seeing what they are seeing, be it in terms of good achievement of implementation outcomes or bad achievement of implementation outcomes. But there is very little discussion and introspection and analysis in the studies to sort of talk about the barriers and the facilitators. We have coded for it, but the number is really small compared to what the total number of implementation outcomes we've coded. The other challenge that we are going to be facing as we start sort of writing up this work is that what kind of conclusions can we be drawing by looking at these results, say for the 130 studies that actually look at adequacy and sufficiency of resources. There may be some studies that are looking at, for example, whether there were growth charts available at Anganwadi centers. There might be another study which might be looking at whether there was a toilet available in the Anganwadi center. A third study might look at whether there was appropriate lighting in the Anganwadi center. So it doesn't really allow us to pool findings of these individual studies and say that, on average, we can say that, adequacy of resources at the Anganwadi center was less than X%, because the studies are not looking at the same indicators within a particular outcome. In terms of implementation outcomes at the frontline worker level or the health worker level, compliance and performance happens to be the one that's been studied the most. There were 143 instances of when compliance and performance of Anganwadi workers or ASHA workers have been studied. And followed by that was, testing these workers, the frontline workers, and at times health workers on their knowledge, awareness, and attitude. Here again, if you look at it in terms of interventions, BCC is actually the most studied intervention. So many BCC interventions look at what is the compliance and performance of frontline health workers. I'm just on the last slide. And so this is the last slide on what do we know about implementation outcomes at the beneficiary level or the participant level. And here again, uptake and compliance is most studied, and not surprisingly also coverage, because there are many, many studies that would give us a coverage number, not really unpack that number at all, but still give us a number, and therefore it's been counted.
Thank you, Stuti. And number of takeaways from this. In terms of going very rigorously through the evidence to see what we can learn about implementation. And I think one of the large early insights is that the quality of the evidence is lacking in an area where we know we need to do a lot, but the evidence has not been sort of systematically collected to actually give us good insights. Let me turn, and I will change a little bit the order because Dr. Kumar will have to leave us at 11 o'clock. So if you please could talk to us a little bit about, first of all, from your perspective, whether suboptimal implementation of sort of otherwise well-intentioned flagship programs are sort of at the core of India's problem of malnutrition and stunting in particular. And then if you can weave in as well, what you think can be done and what role evidence could play and can contribute to identifying and addressing the challenges, and the role that your institution could play in that regard.
Thank you for having me here. And let me start by saying, prefacing that I am today here and in this sector largely because I just happened to take a course with him, and he somehow felt that this was right for me, and I also thought that maybe it is right for me. And the government also was kind and gave me what I wanted, which is normally not the case. So here I am. So with that bit of by way of disclosure, I think so the first point I would like to make with respect to evidence is that there are two ways of looking at evidence. One is parsing huge data sets and try to find relations between what is impacting the outcome variables of interest. And there are some interesting studies which I have had occasion to see, and it turns out that the major impact on nutrition lies outside both the Ministry of Health and Ministry of WCD. It is mostly to do with how the economy is doing overall. It has to do with what percentage of girls complete 10 years of schooling. It has to do with whether the household has a clean cooking fuel source within the house. And it has to do with the water and sanitation availability to the household. And yet, we parse the evidence around whether this intervention is working or that intervention is working, what is the eventual impact it causes on the outcomes, because it becomes a mission in itself to identify ever narrower and narrower set of interventions, because for the sake of study, for the sake of causality, as causality now seems to become a god, we tend to narrow and narrow, and we cite this paper and that another paper and another paper, and people like me get so much confused what to do in all this evidence, what to do with this, when in fact something else is really determining, or maybe determining, or at least it shows an association. I don't know whether that is what is the causal pathways through which they work. We still are not clear. So let us be a little bit more humble about the evidence that we are generating, or we seem to generate, and its implication on what do I give directions to my frontline workforce. What is, because I can't give ambiguous, on the other one hand, this is happening, but this could also be happening, but this could also be. She is, after all, a 10th class or a 12th pass lady from the community. We have trained her somewhat, but many times the quality of trainings, we are unable to communicate all the messages that we want to communicate. And when I visit across multiple districts, I see 21 modules of what is this incremental learning approach, where we are trying to get Anganwadis through leaving her 11 registers and trying to get her to feed everything on some smartphone through some very fancy software that we have developed, and so on and so forth. And then we try to say that, how do we take care of small babies, a low birth weight baby, what is the messaging that needs to be given around. And it seems that somehow we have still not been able to get in, more so in aspirational districts, because that is a program I'm somewhat closely associated with, and like Jeff, I keep on, randomly going around without any, design or sampling or anything, but we're just going around and finding out what is happening on the ground. And what comes out is that they are thoroughly confused with these big guidelines. The guidelines are technically correct, and I see the amount of arguments that happen across multiple bodies, bilaterals, unilaterals, multilaterals, governments, different ministries within the government, civil society organization, all of them have something to say. And then there is this 500-page guidelines, and God knows who reads those guidelines. I don't know. I have never read any one of them. So the point I'm trying to make is, how do you bridge the gap between what the mind can conceptualize and conceive, of which even, at least from the kinds of things that I get, I am never sure whether, what is being said will apply when we scale it out in the different, districts, with different beliefs, cultures, different ways of, looking at different dietary habits. And we try to see that something in Delhi we can, kind of send a template which can apply universally. That I think is, I may not say impossible, but near impossible exercise is what I understand. And what I see really is, when we talk about, Stuti just talked about compliance, testing of knowledge of the workers, even more so in terms of the attitudes, in terms of the incentives that we give them to perform what they are supposed to perform, in terms of measuring what they are performing at a reasonably timely manner, so that we can give them feedback that, this is not going well, or this is going well, or you are doing well, but the other guy is not doing well. There is no system of accountability because the measurement is not there. The administrative data on the basis of which most programs are run at times come with a lag, at times they are not reported properly because you have burdened them with so much data that, if I were an Anganwadi worker, I'd refuse to work, honestly. For the amount of money that we pay and the amount of paperwork that we have, at least expect them to do, it's a wonder why, and I admire them for their courage to carry on nonetheless. So the point I'm trying to make is, we need to simplify things for the ground workforce. Think about a general in the army. If he says that, the evidence is this and the evidence is that, and the man on the spot is to decide whether to fire or not when he sees the enemy standing there, he will be paralyzed. So we need to make it much, much, much more simpler and easier for people to respond to. And the last bit about Global Hunger Index, as we understood, it's not a very pretty position to be in, but it seems that, the hunger, malnourishment, and child malnourishment at that. So if you look at the two indicators of child mortality and the other one of malnourishment as measured by the FAO using calorie availability, on those two parameters, we are not doing as badly, and we are improving also fairly quickly. But there are these two parameters where we are stuck, and those are the wasting and the stunting. And I was surprised to see that Pakistan reports a 7% stunting rate, whereas we report a 34% stunting rate. It seems very surprising, but it is true. On wasting also, we are pretty high, about 20% or so. So we had a recent survey of the CNNS data, the Comprehensive National Nutrition Survey. Two good things, a couple of good news has emerged out of it. One is that the rates of stunting decline, which used to be about 1 percentage points per annum, has accelerated to 2 percentage points per annum between 2014-15 and 16-17. There wasn't much really in terms of programmatic changes that we did during those 2 years, except for Mission Indradhanush, which really went after vaccinating the children in a big manner. The Poshan Abhiyan, or the National Nutrition Mission, was actually launched in 2018, before which the survey was already completed. So I don't know what is suddenly changed over these 2 years, which would lead to a sudden acceleration in the decline of stunting. On wasting also, it seems that we have come back about 4 percentage points in these 2 years. So we are about now at 17 percentage points. Now again, we don't know what is it that we are working. Anemia levels, which were reported 50% plus, is now apparently, as per this survey, is about 40 percentage points, and they tell me it is primarily because the difference, whether you draw venal blood or you draw blood from the fingertip, but maybe, so I don't know what number to believe, but in any case, either of, if you take any numbers, still it is high enough to be concerned about. And my real challenge is, how do I translate that into actions on ground? And one of the things that I would like to mention, which has happened, at least in terms of at least the indicators which are within the control of Health Ministry and WCD Ministry, under the aspirational district program, because we measure households and through a randomized household surveys, and it's almost like a panel data once every 6 months. So those parameters which are being measured, certainly because the districts are looking at it in a much more focused manner, because there is support from civil society organizations which augments the capacities which are available at the district level, with the same money they are able to make a huge movement. I will give you 1 or 2 examples. On diarrhea, one of the things was diarrhea is probably one of the causative factors which could result in death also, and it could result in the child being malnourished. So one of the things we were pushing was to try to look at increasing the penetration of ORS and zinc usage in cases of diarrhea. We have seen almost 25 to 30% movements in 6-month period, and as surveyed and as reported by households. So it's close to truth within the limit of the measurement error that is usually done. But at a 1,000 household sample, I think it's a fairly decent estimate. So it is possible to do, provided you focus, you measure outcomes, and you keep on feeding this back to the community, not to punish them or to penalize them, but just as way of feedback that this is how you are doing. Can we think about doing, and giving a little bit of a process flexibility. So 4 elements. One is measurement of outcomes, which is independent of the agency which is executing it. Number 2, analyzing them centrally, giving a feedback to these people. Secondly, some amount of very little, even non-monetary incentives can work, just to say that, these 3 districts were the best in the last 6-month period. That also itself is a sufficient motivator. But if you can top it up with 1 crore of rupees or something per district for, as untied funding to meet any requirement which is not usually met through the normal government programs, that is good enough. And thirdly, giving them a little bit more process flexibility, so a little bit more freedom to tweak the guidelines suited to whatever is the local need and requirement. And fourthly, a little bit of a support in terms of technical capacities, because I think we are trying to find technical fixes to what really are governance problems. These are governance problems, these are capacity problems. This won't go away simply because you try one intervention or the other, because all these interventions are small, maybe some work, some may not work. But I think given that you have limited bandwidth, limited time at your disposal, the opportunity cost of experimenting and failing again and again is just too high. Thank you.
Thank you very much, and some very provocative as well thoughts there that I will. So first of all, I'm wondering, Purnima, whether you've been dedicating your life to as a nutrition expert to help move the needle on these indicators, and have you been spending it in the wrong sector? Should you have been working on income redistribution in India or something like that? So just a minor question on that, but also following up on whether. You asked us to do this work, and what are your plans for this? How are you planning to also work with the government of India, and drawing upon this evidence?
Great. So a lot of things keep me awake at night when I think about nutrition, and I think those of us who work on the topic and for all our lives, in a sense, have always acknowledged the underlying social determinants of the challenge. There's no doubt about that. So, we talk, I think, sometimes with an equal voice about the role of poverty, of inequity, of gender-related challenges, especially sort of big-ticket ones like, early marriage and early pregnancy, and our research in general has covered all of those. But on this particular topic, this slide in the back is what keeps me worrying. And I think it should keep a lot of people awake and worrying at night, especially those who are trying to scale up interventions. So this is just one snapshot of data from India's National Family Health Survey. It doesn't really matter what's on the top. So what's on the top is a list of interventions. What's on the left is every single state in India. Every single one of these interventions is fundamentally, in the way that Alok spoke about it, evidence-based in sort of a narrow sense of, if you deliver that intervention, research has suggested, not just individual studies, but meta-analyses have suggested that they have a set of impacts related to those interventions. We also have evidence that suggests that if you deliver all of them together at scale and with quality to about 80 to 90% of the population, that you can trigger accelerated changes in stunting, right? So that's why I worry also about health and nutrition interventions. But what the data is telling us is, in a robust policy context that has recognized that these evidence-based interventions are important to deliver, that has in fact put them in the policy framework, that has put on ground the platforms, really large platforms to deliver these interventions, we have an implementation problem. And the implementation problem is not a problem of non-delivery across the board. The implementation challenge, in a sense, is of variability. So, my statement related to this, in a sense, is that you have a robust policy environment that includes evidence-based interventions and delivery platforms, but the reach of the interventions varies, and certainly, my sense is the quality varies, but we have less data on the quality. So I really, at some level, I think we're at a point where the discussion in India is not about policy anymore. It's about what can be done in policy to support accelerated implementation and quality, that, in a sense that both leads to increased reach and to increase quality. So what I want to see on a graph like this, say 3 years from now, 5 years from now, is that every single box is blue, which would mean, so blue here is that over 75% of the population at need receives the intervention. That's what I would love to see. And I think that implementation research can help identify how to close those gaps. We don't have a consolidation of that implementation evidence for India, and that's why we commissioned the work. And so what I'm hoping is that coming out of the work, and I know it's in progress and is really accelerating also, because we're at a really good point now, is that we'll be able to say, okay, on say the food supplementation set of the interventions, this is what the evidence is telling us from India, not globally, about what some of the challenge areas are or what some of the success areas are. On behavior change, this is what it's telling us, and for these population groups, that's what it's telling us. So, I'm a researcher, so of course I believe that research also has a role to play in helping support implementation, and I'm happy to see our policy colleagues nodding on that. I mean, we've been partners in a sense in moving this dialogue on scaling up intervention. So that's why we commissioned the work. And we really thought that 3IE would be, because you have this evidence lens and have done these gap maps. And I know it's been a learning journey for all of us as well, in developing this and moving beyond effectiveness to looking at implementation outcomes. So I'm really thrilled, actually. I'm dying to see what comes out of it. And the good thing is, because we're doing it in India, because we're connected with the policy world here, a lot of the work that has been done by the 3IE group is, already has been moving. For example, I know, Niti has commissioned a study on ICDS, and, the base literature that's been gathered on ICDS has already been shared with them. So I'm hoping that, by virtue of all of us being here, physically in the same policy context, in a sense that we can also accelerate the process of uptake. So, that's something that I think we all still need to talk about. Thank you.
Thank you. Now, let me turn to Carola. And one thing, you were leading this development effectiveness division in the IDB. You get to sort of dive into sort of understanding what sort of, what drives development outcomes in programs. And particularly, when the desired outcomes are not achieved, how often do you see that this comes down to implementation challenges in general? And if you could also reflect on how many, and this might come as partly as a bias of my own, sort of having been involved in some, developing some of these programs, how much, of these challenges could have been mitigated with better knowledge or with better sort of understanding of the realities on the ground?
I love that phone. I want it. So thank you, Marie, for your questions. Since you introduced me as having 25 years in development, these are going to be confessions of implementation sins on my part, and some I think are very relevant to the discussion today. I think, let me just reflect a little bit about how we approached development about 25 years ago. I think, and why we're discussing implementation today. In my mind, we used to believe that if you had experts on the ground who knew the subject matter, that's what you needed, because they would know what to do. And then came the evidence wave and said, no, this is not just an art, it's also a science, and we need to bring a set of parameters that tells us that outcomes are being achieved at scale, and they're replicating, yes, external validity, in different contexts and in different countries for that same particular outcome. And I think today we've evolved to the implementation conundrum, which is the black box. So is it that we are not seeing an advancement of outcomes because we're not doing the correct treatment, or is it because we're not implementing the treatment? And I think there are elements of both. And I think, we are, at least at the bank, we made a huge advancement in terms of trying to understand if what we're supporting is based on evidence, and then trying to measure if that outcome was true. And sometimes it happens, and sometimes it doesn't, or sometimes it doesn't in the magnitude that we expected. And so now we are like, why is that happening? And is implementation the difference in what we see in the external validity of some of these results? And I think it's not that surprising. The answer is yes, of course, it is. And it's a lot less complicated than we think, in my experience. And I'm going to start with one myth that I believe it's pretty prevalent in the way we talk about implementation. And it goes back to the expert. How many of you have seen that Hollywood movie now called Sully, Captain Sully? The man that, US Airways, there was a US Airways flight that crashed into the Hudson River because some birds went into their engines. And the press hailed Captain Sully, and then Hollywood, of course, made a movie about it, for his expertise. He was a hero who reacted and knew what to do and saved the lives of everybody on the plane. And I'm going to bring another perspective to what happened, which is what Atul Gawande mentions in his book, The Checklist Manifesto, and he's my hero, not Sully, because he demystifies this thing. And he looks actually at what Sully did. What Sully did was follow the checklists that any pilot has for a specific set of incidents that they might encounter. And that's based on implementation evidence on what pilots should do that has been accumulated by the aviation industry over years. And apparently the checklists are this big, and they're short, right? So was he a hero? Probably. He saved the lives. He can be a hero. But why was he a hero? He wasn't a hero because he was an expert or a wonderful pilot, better than the others. It's because he followed protocol, right? And I want to discuss this because I think in the implementation of a lot of our programs, we talk a lot about impact evaluation or evaluation of outcomes, but we don't talk enough about monitoring and protocols on the treatments that we are implementing on the ground. And these, please, please don't write a guideline. Don't. Write a checklist and improve on your checklist. Think hard and long about what are the 5 to 10 elements of your treatment, independently if you do it decentralized and you let governments improvise on the margins and adapt to their context. What are the 10 things, the ABCs, that those people on the ground need to make sure that they follow? Check, check, done, done, to make sure that that implementation happens. And monitor that. I have, and here comes the sin part of confessions of my sins. We were doing a cash transfer program in Honduras, 1998, and we financed, designed a wonderful program, large guidance, manuals about this big, with a lot of details. We thought about all the details. And the program rolled out the first year, and the institution that was rolling it out didn't have the capacity to pay every 2 months, and that was the design. So they paid every 6 months, the families, right? But because the manual said that the amount to be transferred was, let's just pretend, I don't remember what it was, but let's say $50, they transfer $50 every 6 months, not what they should have transferred, because they weren't doing it every 2 months. Now that is an error, operational error, as they're called, but that had a huge impact on the consumption levels of the families that were receiving this. Now, how did we find out about this? Because we had to go out into the field and do a baseline survey for our impact evaluation. It was the most costly way of finding out that there has been this implementation error in the field. So again, these kinds of things need to be monitored on a day or on a monthly basis, but you need to think hard about what you're monitoring. What is it that you must have happening on the ground? And I come to nutrition and the experience of nutrition in Mexico. We knew that families were sharing the supplements, the iron supplements that we were giving them among all their children, those with malnutrition and those without malnutrition or at risk, because that's what a family does. I'm not gonna, me, who my children might, don't need any supplementation, I'm not gonna give one more than another. It's not medicine, it's food. In their understanding of it, right? And yet, we did nothing about it. We needed to make a quick decision to say, let's feed everybody. It's still targeted. We're just, not the children at risk. And let's measure it, because we won't need to get the supplementation in. So it's those feedback loops on the treatment that really need to be monitored in order these huge investments to really have the effect that were demonstrated somewhere else. So I have no idea how long I've been talking. You haven't lifted the, so I think I'm good.
But I do have I want to interject with one. So you have the checklist and so on. But Dr. Kumar also raised this issue of incentives when he talked. And you know, how do you incentivize the implementers on the ground to follow the checklist? Any thoughts on that?
And checklists can be incentives in and of itself. You can they're hard, but for example, at the IDB, we have a checklist to make sure that what you're proposing as a solution is based on evidence, and if it's not based on evidence, you have a strong evaluation framework to test it during the life of the project, right? But that's a checklist. But we added to it a point, a grading scale, right? Short, yeah. Development, yeah. All our economists love it. I'm very popular at my institution. So somebody can have an A and somebody can have a B. And the proposal, it's graded. And so that creates an incentive to start conversations about improving. What is it that I'm missing? What is it that why did I not, fulfill that checklist? And what does it mean? Why is it important to do that? And for those that haven't read it, I highly recommend you, if you don't want to read it, you can watch the TED Talk, the Checklist Manifesto by Atul Gawande. I think it's a wonderful, simple idea of how we forget the simplest tasks in implementing. And that has a huge effect on outcomes. Thanks.